proposition. Although there could be professionals who actually try to take us this way or the other way, unless and until we are very clear, very briefly, One Care was a good proposition, very futuristic proposition, but it was
evidence-driven and impact. And this is something that we really need to be able to see. So, thank you so much for that presentation. And as you can see, we have a very good lineup. And I have to set the ground rules here. Tan Sri has already gotten his time slot. So I'm going to get to the other two. Sorry, Tan Sri, this is how it is. So what I'm going to be doing is I'm going to have a few questions I'm going to pose to our speakers. And we have 3 segments of this session. And the first one is about the tenure in office. And Tan Sri, you put it very nicely in terms of your period of being in office. After which we'll go on to looking at successes, failures, near misses. And then the third is about going onwards to the future. Where can we go from here? And this is where we would want to be able to get your thoughts on it. And I'm sure you would all agree with me that you would want to hear them share their thoughts. So because of that, we are not going to take any Q&A unless we have extra time. Boleh tak? Okay? Unfortunately, it's like World Cup, you know, there's extra time, but we don't have a lot of time. So I just want to make sure we get the maximum from our speakers here today. So let me just kick it off then. Tan Sri Subra, when you came on board, first 100 days, you saw what was going on in the portfolio that we were given handed responsibility. Dr. Zul, the same thing with yourself, and sorry, if I may call you KJ, it's just used to call you KJ. KJ, you also saw your portfolio. But one of the things that Malaysia has always been touted as having is universal health coverage. And perhaps even the argument is that we've had it since the 80s. And perhaps this is something that we don't fully maybe understand what does that mean to have universal health coverage. So let me just ask Dr. Zul first, and then KJ, and we'll go to Tan Sri. Dr. Zul, do you agree about whether or not Malaysia has universal health coverage? As you understand it. I mean, never mind the civil servants briefing you, but yourself.
Thanks, Dr. Zul, and Analyst Subra, KJ, and distinguished esteemed officers and guests. All right, let me begin by my usual Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam kerajaan perpaduan. Bagi political landscape. Right, I'll go straight. Not using my high mirror and reverse gear though, this very, very precious time that we have together. Right. If universal health coverage is to be defined as all people accessing health services without any financial hardship, very bold indeed, a very bold statement and loudly so, I would have to take it with a lot of qualification, whether did we ever have it. But I must say that Malaysia, in those early years, we were, until very recently, were in fact, quite well regarded. Overperformer in some sense, particularly with our MCH, maternal and child health, no doubt about that. Yeah. But if this definition is to be applied to the entire nation as Malaysia and Borneo State, Sabah, Sarawak, you can't, dissent and disagree with me that the memory and those very sad, harrowing moment of the case of Kam Argo, clearly depict to us of how the yawning divide of accessibility, let alone quality healthcare, And to give you a snapshot of what recently happened, just few days ago, infant dies in the arm of mother on a 6-hour bus ride to hospital in Sarawak State capital. Very diminishing of what happened to Argo. She had to travel 6 hours at 8 checkpoints, and that is the most daunting of all experience to overcome that. So really, Azrul, in all fairness and in all truthfulness, be told, I would dare not say that we had really achieved it and sustain it, as the Timbalan put it, sometime, heavy rain, whatever. But then again, we really wasn't there as yet. We almost were there.
Okay.
But I must say in all honesty, we must strive towards it. But going by this, and you all know very well what happened, in these cases very recently. So it goes to show that we do not have as yet, equal access. And without financial hardship is a qualification that's stressed by the WHO, UHC.
Okay.
So I put it that way. But I'm a perpetual optimist, whatever that means to you. I believe that we will have to strive together and to achieve that. Yeah.
Thank you, Dr. Zul. I'm glad you mentioned about the East Malaysia case, the Sarawak case. Actually, there were more than one case.
Yeah,
and
we have got a few cases.
Yeah, so we'll come into that in a short while, but I'm glad you mentioned it, because the understanding of what is universal is one that's debatable. Tuan KJ, what do you think? Universal health coverage?
Thanks, Azul, and thank you to my two elder seniors here. I was hoping not to join your club so soon. But unfortunately,
That t-shirts.
I'm now part of the club. So coming to the question of universal health coverage, just wanted to expand a little bit on what Dr. Zul mentioned. It's the accessibility to quality healthcare in a timely manner. I think those are the two words that I feel very strongly about when we talk about UHC, which is quality healthcare in a timely manner. And I think on those two very, very important criteria, we meet it sometimes, but not all the time. And I think that's the general consensus here. If you look at the national health accounts from 2020, you'll see that health expenditure in Malaysia, about 46% is expenditure directly from the Ministry of Health. But most alarmingly, 36% now is OOP, or out-of-pocket expenditure. This is money that people have to spend from their own pockets. Not covered by the government, not covered by insurance. This is expenditure. Now, why in a country where we have a strong tradition of UHC, we have, 2,000 plus Klinik Kesihatan and Klinik Desa around the country. If you do a radius of Klinik Kesihatan to population, it's not more than 5 kilometers. Normally you'll find a Klinik Desa or Klinik Kesihatan. But why is the OOP coming up? And that's because, one, chronic underinvestment. We all know this. That's why we made a big deal about this 5% of GDP within the next 5 to 10 years. And secondly, because of that, people are not getting quality healthcare services in a timely manner. That means that they cannot wait. For many of these cases, chronic cases and otherwise, the wait time is too long. Yes, you have UHC, because if you're willing to wait, you can see a doctor at the end of the day. You can see a specialist at the end of the day, at the hospital, at the Klinik Kesihatan, but you may have to wait. And some people don't have the luxury of waiting, as we know. When you're sick, you want to see a doctor as soon as possible. So I think on those two counts of quality, in a sense that do we have the right investment infrastructure in place, human resource in place? We don't. And I think that was a problem that we grappled with, Tan Sri, Dr. Zul and myself, in terms of getting the number of specialists, in terms of getting the contract doctor issued, in terms of getting the right infrastructure in place. And third is secondly is a timely manner. Are we seeing the right people when we need to see them? So those are the two concerns that I have for UHC.
Thank you, KJ, and that is spot on, really. When we want to be able to evaluate where we are on universal health coverage. And Sri, not to put you on the spot, but because you have the benefit of seeing your your successors take over the job, and to be able to work on this portfolio, have we improved, or has it worsened over the past 5 years? So not to judge Dr. Dzul or KJ, but you know, we're friends. It's a safe space. I mean, based on the indicators that KJ mentioned just now and some of the issues concerning coverage that Dr. Dzul mentioned just now, where are we?
Thanks, Azrul. You know, when you ask politicians this kind of question, they'll give you political answers. Of course, it has improved. I mean, I will never say our health system has deteriorated or not. I think to a great extent there have been improvements which were done during, for example, the opportunities for the poor to get access to some things which they could not get before through programs like PACA B40 and all that have actually bridged certain gaps which were in the system. So this is important. I think let's see this correct perspective. I'm sure you have traveled, I've traveled, all of us have traveled. We have seen health systems all over the world. I am still trying to find the ideal health system in anywhere in the world. There's no country in the world. I was in the US, I think it was a disastrous health system. I would not like to be the US and fall sick. It is disastrous. The British health system, the pride, so much of Commonwealth Games, NHS actually went on the march. But that collapsed during COVID and post-COVID. So there's no ideal health system. I think Malaysians should, and for the amount of money which you are spending, we should be very thankful that we got such a good health system. This is very important. You must look at it in the correct perspective. The perspective is, see, we have taken a historical decision that every Malaysian born in Malaysia forevermore has the right of treatment in a public health system for A to Z free of charge. This is a statement. Now, is this statement tenable? Is this statement sustainable? Over a period of time, again and again, we realize that this statement is not sustainable. So we need, but we didn't have the political will to examine that statement and do the things which are needed to put the statement right. Only when we do that, then the problems which Dr. Dzul created actually can be, you see, during a white paper discussion, I think there's Sarawakian, I think there was an NGO from Sarawak, brought this idea that resources should be distributed based on data. Yeah. And this is something which is a very, I think you went, it was in your town hall session. Right, resources should be distributed based on data. If we use that process, we will be able to actually allocate resources exactly where it's needed, so these holes are actually bridged.
Okay. And I think this is one of the tenets of public health policy is really evidence and needs-based and impact-driven. And definitely, this is one of the ongoing discussions that still are being discussed, you know. And you mentioned just now political will. And unfortunately, Sri, you opened a little bit of a Pandora's box there with the financing part, but we'll get to it in a short while. But that in itself is a controversial issue, and you highlighted it during your presentation.
Because that's the basis of everything we are talking about.
Exactly, and it's fundamental. But let me say this, you know, you've had the benefit of, everybody here has had at least a year or two in office and looking at it. Now, if you consider the first 100 days, when you were taking charge, what was on your table that you needed to address within the first 100 days that you felt was it legit, could be done, and you did? KJ, first 100 days.
Seriously?
Yeah. I'm putting it out there here. In case people have forgotten already.
When I was appointed on the 30th of August of last year, 30,000 cases a day, 300 to 400 deaths a day from something called COVID that you might remember. So my first 100 days was really to try to make sure that was peak Delta. You know, Dr. Yati remembers very well the nightmare that we were in. Thankfully though, we managed to come down from the peak because of the vaccination program. But it was important to make sure that that first 100 days, those first 100 days were dedicated towards making sure that we had the right preparation, just in case there was a surge, just in case we couldn't come down from the peak for whatever reason. And it was good, because we ended up coming up against the Omicron wave in early this year. So I didn't have the luxury of looking at long-term reforms and things like that. It was just life and death for the first 100 days. So that was all I was consumed with.
Thank you, KJ, and I just brought it up just in case people have forgotten. COVID-19 is still going, and some of the successes that occurred during that time. That's the first 100 days. That was in 2013, right, if I'm not mistaken?
Right.
Yeah.
Yeah, it's quite a long time because it's selective amnesia or something. So, yeah, I mean, I didn't have the privilege of dealing with COVID. But we had another epidemic. That was when I think our national obsession was NCDs. So NCDs was our national obsession at that time because the data was disastrous, 17% prevalence of diabetes, 34% hypertension, 44% cholesterols. Half the nation is obese, and we had Faisal was there. We had the singular pride of being the most obese nation in Southeast Asia. I think we're still holding the title.
Still Brunei.
Oh, Brunei!
Oh, Brunei now. Brunei.
That should be a case study there. So this was the first thing. So how do you go into the long-term trajectories? And I think one of the earliest things I did a very simple, low-hanging fruit, is we were a country who was subsidizing sugar. Malaysia was subsidizing sugar. I mean, I couldn't believe why we were doing this.
The only country, apparently.
Yeah, the only country in the world with subsidized sugar. And we were giving nearly about 30% per kilo was subsidized by the government, or to some degree like that. So we removed that. Of course, Cabinet was again a bit worried whether this removal of the subsidy of sugar will have impacts on the rural population, which is culturally very sugar prone. And thank God, two things came out of that. One, there was no repercussion, there was no people fighting against it, so the people accepted it. But later data, which is the most unbelievable, that the amount of sugar sold in the country didn't go down. Didn't go down. Actually, it didn't go down. This was data based on manufacturers' amount of sugar which was being bought in the country. The amount of sugar consumed or being sold didn't go down. So Malaysians readjusted to a higher level, which shows us we haven't gone to the breaking point of sugar cost. I think this is everything. There's a breaking point, you know. Breaking point of sugar cost, which I don't think we have reached that level. So this is something which when will we reach the cost which lead to reduced consumption. And that goes for everything, sweetened drinks, all the other things, whether we have gone and implemented our tragedies sufficiently high so that actually consumptions becomes low. I don't think we have reached that in anything. So that is our singular setback in this process.
And Tan Sri, if I'm not mistaken, there's a discussion right now that's happening concerning the price controls for sugar and whether or not it should be taken away or, brought up further. And obviously, people are protesting against the possibility of their Milo dinosaur being more expensive or teh tarik and so forth. So that's an ongoing conversation still. And that was still something that you had to face within the first 100 days. Dr. Zul, first 100 days for you, 2018,
Right.
was that March, maybe?
Yeah, 22 months, yeah.
I'd
First,
like to take almost 2 years.
yeah, it helped. First 100 days, you know, despite all those perennial firefighting issues that I have to attend to, I was quite clear that I must lay down reform agenda for the next 5 years. Very hopeful to see one term like our country, 5 years, but we are only less than 2 years. But be that as it may, I laid down the reform agenda. And incidentally, I had this document that I presented to you know, on urgent recommendation for health reform. And it was supposedly to be tabled to cabinet and subsequently, you know, tabled in the parliament. Now, first 100 days, as I said, I was very sure that I'm going to quickly address the perennial problem of junior doctor quandaries. You may have heard what I took a very serious action on a particular person. And then I'm very sure that I'm not going to go this way of going through building more bricks and mortars, but rather to move away from an over, you know, I'm not saying obsession, but an emphasis for hospital-based curative care to one which I thought would be the demand for the future of Malaysia. That is, this epidemiological transition from infectious disease to NCDs. Hence, you know, my primary effort was to focus on going preventive, promotive. Hence, you know, that underscores the underpinning reason and thinking of PKB 40. Yeah, because we really want to see, you know, nation addressing NCDs, notwithstanding the need to increase all the other things on our infra by way of hospital-based curative care or the continuum of care from primary to, you know, rehab to palliative care, whatever. But I was very sure that I want to address the pandemic that's coming, that is NCDs, and not realizing that immediately I have to face the COVID-19 pandemic. So really, 100 days was focused, and you may or may not have realized, unless you've forgotten that I have 22 initiatives in 22 months. Some I managed to roll out, like PECA, pneumococcal vaccination and others. But, and I called for, you know, emphasis on not just primary health care or the primary, you know, but one that provides the mechanic of doing it, of how you could actually rope in and integrate the private practitioners into the primary health care as a means to enhance further our capacity to address the NCDs, particularly on screening and as well follow-up with treatments. That were the emphasis, and notwithstanding as well, I have my eyes on healthcare financing, and this is to me the linchpin or the crux of it all, because the inability to address and redress a predominantly tax-based healthcare financing, which is untenable, unsustainable. That is an agenda in my recommendation, and as well called for, in that sense, the dichotomy of public-private, you know, services to be broken down by the ability to have what I call as the National Health Trust Fund or National Health Fund funding, so that we can strategically purchases and making purchase for both public and private. But most importantly is my emphasis on PKB 40, which after I, you know, we almost screened 1 million when I left, and I brought this issue in Selangor, in the South Fact, this Selangor Public Health Advisory Council. We already screened 1.4 million on including beside the you know, the colorectal cancers, you know, prostate, breast, and as well spinal cancers. So these are very important things.
I mean, these are legacies that you have actually, and it's continued on even through KJ, and now hopefully the new health ministry leadership, we continued on because Fricka 40 has shown, and you're forgetting also that besides the voluntary health insurance that you were trying to roll out but wasn't able to, you also had the banning of smoking in eateries, which was a really good legacy, and I'm hoping that it will be continued on, because people feel that when leadership changes, you don't need to follow that anymore, and we've seen that happen, and this is
we've got to address other things as well.
Exactly.
Besides, purely, medical things like the social determinants.
of course.
We finally, impact.
So speaking of that, and KJ, you've read obviously the cases in Sarawak where a woman had an infant girl in her arms, traveling by bus to Kuching to seek medical treatment, and then there's another case of an elderly woman who was held up at the immigration checkpoint for several hours, and despite heroic efforts by the ambulance crew who were doing continuous CPR, she passed away. She didn't make it to where she was supposed to go, which was to a hospital, which she would receive emergency care. And arguably, when presented, you could argue that this has nothing to do with the health system. This is other things. The guard who went home with the keys to the immigration gate, the bus, the woman who didn't know whether to take the child to a nearby clinic or a hospital, etc. So here's the thing. We've known for years that healthcare in East Malaysia is in a certain state, and it's still inadequate to cover the needs for Sabahans and Sarawakians. We've known this for many years. So I'm going to ask a provocative question here to you, KJ. Should the health minister be a Sabahan or Sarawakian before there's going to be more emphasis or priority on what's happening in East Malaysia? Is that where we're going? Because all this while it's been Semenanjung health ministers, so should it be somebody from East Malaysia? Or should it be that we devolve some of that to give them more autonomy on managing health for Sabah and Sarawak? Go ahead, KJ.
First of all, I'd like to point out that the Deputy Minister who's with us today, YB Lukanisman, is from Sarawak. And my deputy also was from Sarawak, Datuk Aaron, who's now the Minister for National Unity. So we've had deputy ministers from East Malaysia at KKM. I would like to think that you don't need a minister from a particular state in order for you to service that state well. A minister or a deputy minister should represent everyone. So the short answer is no, not necessarily. Obviously it helps having a voice from Sabah and Sarawak at the table. There's no doubt about that. I presented just a couple of months before the election, I think senior management of KKM were there, to the MA 63 committee, a bold plan for Sabah and Sarawak, which in addition to creating 2 more state GH level hospitals in both states. Now every state has 1 general hospital, and we presented 2 additional state GH hospitals so that you have better geographical breadth. And following from that, not just the elevation of Hospital Pakar Major into GH, but Hospital Pakar Minor into Hospital Pakar Major, and Hospital Tanpa Pakar into Hospital Pakar Minor. And that's not just words. Those means that means that you add specialties in hospitals, which comes with cost, which comes with manpower, and which comes with commitment. We also presented the need to have 1 super primary healthcare clinic in each district to anchor all the clinic Kesihatan and clinic bases within Sabah and Sarawak. And that was well received by the state governments who were at the meeting, the MA 63 meeting, and it was endorsed. It was endorsed as something that the central agencies, in particular EPU, and the Ministry of Finance should commit the resources to over the next 5 to 10 years. Yes, I do think that the commitment and that plan should continue. But I just wanted to add something about what was mentioned by Dr. Zul and yourself about factors other than within the healthcare system. I think that's crucial. if we don't continue this discussion about non-medical determinants of health, what people now refer to as SDH, social determinants of health, then we're really not going to get anywhere. Because you're talking about education, you're talking about poverty, you're talking about housing, you're talking about access to nutritious food. If all these things are not addressed, then the NCD disease burden will be compounded. And all you do is to try to treat it, which, as we all know in this room, it's too late. So I think, and I hope, and I mentioned this yesterday when Miluk was there, when I saw the minister, that the focus on SDH, social determinants of health, must continue. That started with Dr. Subra, through to Dr. Zul and myself. GEG is a great example of that. Why are we obsessed with GEG? Why are we obsessed with smoking at the Ministry of Health in restaurants, or cutting it out for a generation that's born after 2009? Because we know the science is clear, the evidence is clear. Even though the Minister of Tourism, when he debated this as a backbencher, I'm going to call him out on it, your good friend, Yang Muhammad bin Tulu, had the nerve in Parliament to say that smoking does not cause cancer, which is absolute BS. We know this by now.
Thank you, KJ. And I certainly must echo some of the points that you mentioned just now, especially on the need for us to be able to look at it that people are to serve all Malaysians, not just one particular constituency. And certainly with now with a deputy minister who's again from East Malaysia, we're hoping some of those concerns, because I'm seeing YB Kelvin also in the audience here as well. I know he's looking to a lot of changes in the East Malaysia side, and certainly we need to be able to address the social determinants, and that looks at more than just the health portfolio. And too easy is it for us to just blame the health ministry or put the burden on the health ministry to solve all those problems that we are seeing coming into the hospitals. And that really goes back to things like affordability, access, coverage, and so forth. Now, we come to this next section, which is concerning success, failures, near misses. So I'm going to give you guys a moment to think, but I'm going to start off with Tan Sri first, simply because you gave your presentation just now. It looks like you have your list already. Success, failures, near misses. Just pick one. Success first, Tan Sri.
I think I already talked about the successes and talked about the failures. I mean, things which we couldn't get through. For example, one is this idea of getting the government to recognize that this statement that everything will be free forevermore is non-sustainable. So that couldn't, because again, this is a political will. As I was telling you just now, we just take dental treatment. It's non-emergency. Dental treatment. People from Singapore, those who are working in Singapore, Malaysians working in Singapore, will drive to Johor Bahru and Johor for all their dental requirements in our government clinics, because we are probably 1/10 of the cost which they have to pay in Singapore. So when we want to increase the cost of this, suddenly these are non-invasive things like scaling, implants, for example, where to reflect the real cost of what we're doing, there was no political will to actually implement. I think that was one issue. And I must say, I think to the audience, the cabinet as an entity sometimes doesn't look at health the way the Ministry of Health looks at it. I'll give you one more classic example. This is pertaining to cigarettes, right? The cigarette industry decided to bring what is called kiddie packs, as an innovative method of reducing illicit cigarette. So they sold it to the Ministry of Finance, they sold it to the Ministry of International Trade. If we bring down the packs from 20 to 7, our cigarette costs will come down. And we had this fierce meeting chaired by the Prime Minister, everybody was there, and they flew in a guy from overseas, somewhere from South America, to present the case, who came in, really said the government will get so many $1 billion in terms of revenue if you actually implement this kiddie pack. So everybody, Ministry of Finance was for it, Ministry of International Trade was for it, Prime Minister was for it, because you're getting a few $1 billion out of it. So the only ministry which is against it was the Ministry of Health. And the only Ministry of Health was against it. And the last statement I had to tell PM was, what is the moral story you are trying to transmit to our young generation by reducing the cost of cigarettes? Then he stopped. Say, we will not make a decision, we'll decide it later.
It sounds like a success, though, that's
Okay.
tricked us there. Near miss, that's right, near miss.
Right.
Has there been any near misses?
Yeah, I mean, our attempt to extend primary health care to be more effective, more community-centric, and we missed it. But I think I hope it will continue on.
Okay.
Thanks.
Thank you, Menteri. Dr. Dzul,
Yeah.
success, failures, near misses.
Right.
Just one of each.
Success, I think it's nothing to shout about, but it's already in place, and hopefully it's going to be enhanced. PKB40.
Okay.
That PKB40 epitomizes the emphasis on primary healthcare. Achieving UHC.
Okay.
That is what it is. It's not just that branding of PKB40, but it's whole entire thinking on healthcare, which is fundamental. And
Failure?
Failure, I must say that I really wanted to address this, but maybe I'm going to be given a bit more time on what I thought, to achieve UHC, although this presupposes that you have the basic infra, is actually digital health transformation. And that is fundamentally the backbone and the spine of it all, which is the EHR or the EMR. Not the HIS per se, it's more like hospital information system, but this is actually, the one that will seamlessly allow patient to go wherever on health facility, horizontally, vertically, but providers and healthcare providers could see in the master patient index of the patient. A patient must not be asked the same question twice.
Near misses.
That's what I would want to address. That is something that I really wanted to go into. No, not really. I mean, whoever goes in, whoever goes in. And I spoke to Seri when he was minister. I said, make this your legacy. Of course, he didn't have the chance as well. But really, this is something that we must. It's almost mandatory that after 2 decades, really, we spent almost 2 billion. And all I could say there is about 30% of our 145 hospitals and Institute of Health that have a semblance of a digital health. I wouldn't want to say more of our case of Siam Hospital. It's now come back to be, I think, that is such a
there are so many left undone when it comes to even telemedicine. We consider the fact that the Act remains ungazetted. And arguably you actually have to review and write a new law for that, right?
I mean, avoiding those cliches and buzzword or whatever, I want to get down to really patient care and population care. That will be the real thing. Getting to and analyze, doing big data analytics on data-driven decision for future management of population health beyond just patient care management. So this is it that I personally find it like I really felt that whoever takes over must it's almost like mandatory to give and whichever the government is must provide for a reasonable allocation, because I wanted the idea that we will spend in 5 years 1.5 billion, and for a start was to be allocated into 2020 budget of 31 million, and thereafter it just fizzle off. So that is the misses. What else?
Well, we can stop there.
I've talked so much. Yeah.
No, it's okay, Dr. Dzul. But what to go to KJ? Success, failures, near misses.
I mean, I hate using the word success because everything's work in progress. But if there was a high point, it's breaking down side-by-side walls during COVID. Let me explain what this means. COVID was entirely whole of society, and whole of government and the whole of society. We work together with all the NGOs, National Cancer Society doing the vaccination program. We finally, after PKP40, which was a great start, we managed to roll out a population-wide program through our private primary healthcare providers, which is the vaccination program and also the COVID treatment. We have, well, what is it, Casey? More than 9,000 private clinics around the country, not fully utilized, PKP40 to some extent, but not. We managed to use it for the vaccination, for Paxlovid, for treatment, for issuing the home quarantine order. We work together with community pharmacists. We train community pharmacists to give jabs. It's common in other countries, but never done before in Malaysia, and finally they got to do it. And breaking down these silos was so important, and I hope we keep on doing that. The other silo that we broke down was data. Data was so closely kept and guarded by KKM, and I love the folks at KKM, but there was this veil of secrecy that you cannot share data, but you know, DG was very good in terms of pushing for this as well. We just uploaded everything, line listed, anonymized data on GitHub so that everyone had access to it. And
failures.
Okay, the biggest one that hurts, well, that still gets me is we didn't take the GG across the line. And we were almost there. You know, Kelvin, Dr. Zul, Luke, and I worked very hard. There were some amendments, yeah, valid concerns. We just ran out of time. I think, you know, I was going to table it after the budget debate, but we knew by then that we didn't have any political time left. So I really hope that those who are still left in Parliament can push this through. Near misses. Human resource. We managed to get 4,000 permanent positions last year, the biggest increase since the contract system was introduced in 2016-17. But there were a lot of things that needed to be done to address it in a longer term. Was it sustainable? What do we do with the increased number of medical graduates that come in every year, the shortage of specialists in the next 10 years. So near misses in the sense that I managed to address it, but not fully.
Okay. Thank you, Gijan. That's really important in your answer just now to encapsulate some of the disruption that's occurred, but also a lot of the meaningful changes, a new way of working even, you could say, that we need to be able to break down walls, barriers, and democratize information. And speaking of democratization of information, I just wanted to touch on one topic very briefly, which is something that Tan Sri Subra, you initiated, was continued on and seen in Dr. Zul's time and then later on KJ, which is the issue of the Hospital Sultanah Aminah fire and the report that until today, after several different ministers, still has not seen the light of day, the inquiry report. And we were actually hoping to see that come out. And it still hasn't come out, despite the Cabinet having already declassified the report during Dr. Zul's time and KJ yourself committing to having it released. So, you know, very briefly, because we're talking about near misses as well, should this report be made available? Because we're talking about reform, infrastructure, and making sure there's accountability. Should this report be released?
Maybe I'll just, because I was the last one there, I think we've all seen the report, and there's nothing in the report that should be hidden. It was just, I'm not sure Dr. Zul and Tan Sri, but for me at least, upon advice of legal advisor, because there's civil suits still against the Ministry of Health. That's the reason why we've held it. Once those are disposed, I see no reason why it can't be published.
And of course, bearing in mind that incident had 6 deaths due to a fire which could or could not be avoided, and something that we need, because we're moving forward, we need to reflect on what's happened in the past to improve. So we're coming to the end of the discussion here, and we really want to be able to end on a new way forward. And gentlemen, all of you have indicated to the new government, for which you may or may not be part of, that you're willing to work with, wanting to work together in improving upon the health reforms, but also to see some of the stuff that you worked on to be carried forward and basically see those changes that have been promised for the 10, 15 years. So in terms of looking forward, where do you want to see healthcare in Malaysia? When it comes to health reform, what would your key message be to this new government in terms of what needs to be done? Tan Sri, because you're super senior, I'll give you first.
Right. There's no single solution to health problems which we have, right? So it's an overall reform which we're talking about. And the latest is the health white paper which was initiated by Khairy. And there's one component of that which I think is very important, if we can get that, is to take it out of the political domain by making it something which is going to be owned in a bipartisan approach and creating a kind of permanent structure which will ensure the continuity of this reform process, immaterial of these frequent changes of ministers of health which Malaysia is unfortunately associated with, and see so that it can continue. If we can actually put that process into place, then whatever it be, I mean, the health white paper which we have been working on for the past year or so is actually a collection of everything which was done during my part, during Zul's period, during Khairy's period, and even those who were before us, is an overall entity. So in implementing that will ensure addressing all those issues which we have in the health system. But the problem with implementation of that is the political will and the political structure. So if we can create the political structure which will ensure continuity, immaterial of that was what we just ingrained in the plan itself. I hope that can be done. If that is done, then we can, I have talked actually as rule on international forums whether we can take health out of politics. I mean, this is a debatable thing. Because very often politics, I don't know whether it does good to health or not. So we have to think very seriously about it. For politics is needed for health. But if these changes don't actually have a positive impact on the health outcomes, then it becomes a problem, like what we are seeing now. So we have to see how we can actually achieve that. Once we achieve that, then the reform process continues. Then whatever we want to achieve, because that is the fundamental, and we have seen that, right? We have seen every time when we want to reform, it's the political process which becomes a hindrance. So once we have got a system which can address that and take it out of that, I think will be developed. So I hope that we can achieve to some degree. We thought it would be done the last time because there was cooperation between all parties. Now you've got a unity government, a little bit undisunited on the other side. Whether we can unite them as far as the health agenda goes, then I think we can move forward.
Tan Sri, burning question, should we introduce social health insurance?
Yeah, I think in the long term, we need alternate financing. I mean, no other choice, right? The 5% of GDP, we get it today, it's a lot of money. But when we take it in the next 5 years or 10 years, then of course our cost goes up. We won't know whether that's actually sustainable. But alternate forms of Malaysians should, but I think we need to educate Malaysians. I mean, we need to educate Malaysians first to the fact that contributing something to healthcare is fine. They are doing it, a lot of them are doing it. But how to get this message politically right so that it doesn't become very hurtful. So I think that messaging is right. So once the messaging is right, then I think people will be more open to the fight of contribution. It could be small, it could be taken step by step, but somewhere along the line I think we have to start. But what form, how, that is to be determined here.
Thank you, Tan Sri. Dr. Zul.
Yeah. Well, I must say that there have been 14 studies commissioned from 1985. 14. And the last was, of course, the big one, the MHSR, Malaysian Health System Research. I think that was your time.
This is the Harvard Ministry of
Yeah,
Health.
there's the Harvard, yeah. And honestly, our 22 months, I put in place a lot earlier on a HAC, Health Advisory Council, led by none other than Tan Sri, Sulaiman and the rest of my Southern Malaysian members, names like, big names like Prof. Ardiba and others, Alex Matthews, Musa Nordin and others, way on from Harvard School. Now, I truly believe that by way of research, until now, honestly, I must, in all humility or rather, in all honesty, say this, that arguably, really nothing big that we can shout of reforms. We have improved, piecemeal though, but a reform that is worthy of a new Malaysia that could really, achieve this UHC, I think we really need to do a lot more. And I believe this, with all due respect to the new minister and his deputy here, you don't really need to reinvent and reveal because you had it all already. What we're doing is to internalize this because these are done by great minds in healthcare, the healthcare sector, both public and private. So really, I would want to see, at the end of the day, this truly health empowering ecosystem where you get to see the whole of government and whole society approach, to truly galvanize and strengthen to get to the best outcome, for the new Malaysia, a unity government. So this is what I thought is so important. Notwithstanding, of course, I don't want to go away from cliche like social health, insurance, whatever. But I think we need to really revisit that. It's healthcare financing in a bigger, generic, but what's important is the real outcome, of having a national fund that could galvanize all that Subra mentioned earlier on about, health insurance. There are privates and whatnot, SOCSOs and even the endowment funds, the zakat and whatnot. We must galvanize it all, and then we could have, a semblance of empowering, a health, fund that could strategically, I say it again, purchase, both public and private, and in so doing, really tear down the dichotomy of public and private. That would be the best way of public and private collaborations. And these are among the two things that I thought, beside of course, the digital health transformation, namely of EMR and EHR, we must work for, without fail.
Thank you, Dr. Zul. KJ, you've seen what's happening. You know about the NCD crisis. I mean, that's one of the reasons why this is being organized here today. We've got 3.9 million people living with diabetes. There's half the population is either overweight or obese. People are living with 2 or 3 risk factors for NCDs. We've got cardiovascular, cancer. It goes on. And we are in a state of crisis today. How can working together, looking at issues like social determinants of health, can we break these kind of silos? How can we work together? Because it's a unity government now, right? So we should be able to overcome some of this partisan issue. I mean, like it or not, health is political, and we need to be able to address this properly. So you've seen it, you've seen the dire situation that's happening right now in the state of healthcare in Malaysia. Any words for you on how we can push forward these much needed reforms?
Thanks, Azrul. Yes, health is political because it goes through the political process, but health should not be politicized. That's the important difference here. But maybe some of you know that I'm a huge football fan, and the World Cup is on right now. So let me quote and borrow from slogans of big sports brands to try to encapsulate what I think should happen. And I did this during the election. When I went to Sungai Buloh, I borrowed from Adidas saying impossible is nothing in trying to reduce a deficit of 26,000. Clearly impossible was everything in Sungai Buloh. But for what we need to do now, and for the new leadership at KKM, it's of course the Nike slogan, which is just do it. Everything has been said, everything has been researched. Don't be scared. We always come back to hesitancy. If we do this, we will lose an election. You can take the country out of COVID, you will still lose an election. So, it doesn't matter. Just do it. Yeah, just do it. You have to have the conviction the clarity of thought, the clarity of purpose to get this done.
You're going to declare your political financing after this.
I'm going to get to that. I'm not
brands, yeah.
I'm not going to shy away from that particular question, but I think everyone in this room, we're all part of the health fraternity now. We've heard it all. We've deliberated all of this many times. It's just about getting it done, and I think it's a perfect time to get it done because of this unique situation where you have this creature called the unity government. So, and I believe that even the opposition will have very sympathetic ears to get this done. Don't politicize it. It is political, but don't politicize it. Now, coming to the big question.
Investment, not spending.
Health is investment,
Health
it's
is
not expenditure. Health is investment, it's not an expenditure. That's what I remember when I went to the same program that Dr. Subra went to at Harvard, there was one module about how to talk to your finance minister. So you have to say, brother, or sister, it's an investment, it's not an expenditure. But coming to the point of health financing, yes, I agree with Dr. Subra, communication is important, but sequencing is also very important. I would say you can start the discussion on co-payment from the public, whether it is through voluntary, whether it's through mandatory, whether it's through a pool that is supported by Zakat and all the other pools of funds that Dr. Zul mentioned, after we hit certain milestones. If we come close to 5%, if we reduce waiting times, because the public ultimately wants to see, if I'm going to pony up something, I want to start seeing some qualitative improvements in the healthcare system. If you are asking me to contribute, and count all of that, if you are asking me to contribute 500 ringgit, 1,000 ringgit every year, but it's the same wait time at the KK, it's the same wait time to see my cardiologist, then what's the point? So if you can show that you can talk to your Minister of Finance, come up close to 5%, wait times come down, quality of service goes up, then you can start saying to the public, hey, let's have that big discussion about co-payment now, and maybe people will understand. The other thing that Harvard teaches you about leadership is about disappointing people at a rate that they can accept. So you're going to disappoint people anyway.
You're going to take that course,
and you must make sure that you disappoint them at the rate that they can accept without booting you out of office.
Okay. On that note, ladies and gentlemen, they all said pretty much that they thought this session this morning was impossible, yet it happened. And I'm glad that we were all here to be able to participate in this discussion and to hear what they have to say. And don't you think they deserve a round of applause? Come on, give it up. This is the spirit of cooperation that we want to be able to see in this administration. And I'm sorry, Dr. Zul, since you're the only one who's still YB on this stage, we're looking to you to deliver. So we have
a few here.
So of course, but they're not on stage. So but in the past. But with that hope.
I carry that fraction. No?
Yeah, and we also carry that hope to our Deputy Minister of Health as well, who needs our support to address many of these issues. We look to you, sir, as well to help communicate to the people in Cabinet, to the Health Minister, and to all of those. We are here to support. We are here to help.
Just do it.
Well, he said it, right? So without further ado, ladies and gentlemen, I thank again to all of you for participating, for listening attentively, and for all of our speakers, Tan Sri Subra, Dr. Zul, and KJ, for being such sports and being here in forum. So without further ado, thank you so much. I hand it back to our MC for
Bismillahirrahmanirrahim. Yang berbahagia Tan Sri Dr. Subramaniam, yang berhormat Datuk Seri Dr. Haji Dzulkefly Ahmad, yang berbahagia Tuan Khairy Jamaluddin, yang berbahagia Datuk Seri Samsudaram, Co-Chairperson of NCD Malaysia, Dr. Murali Munisami, Co-Chairman of NCD Malaysia, and Dr. Alan Fong, Executive Council Member of NCD Malaysia. Distinguished guests, members of media, ladies and gentlemen. Good morning, salam sejahtera dan salam kerajaan kepada. Firstly, I would like to thank organizing committee for inviting Minister of Health to deliver the keynote address and to officiate this event. Unfortunately, she unable to attend and would like me to convey the warmest regards. It is an honor for me to be with all of you today to represent the Minister of Health. Since 2017, the world has celebrated the International Universal Health Coverage Day on the 12th December every year. The theme, Build the Will We Want, a healthy future for all, befit our vision for the Ministry of Health. As well, all know Malaysia has dual public-private healthcare system. The public sector seek to provide widespread coverage of universal healthcare for the population, delivering virtually free primary healthcare services and heavily subsidized secondary and tertiary care services, which is largely funded by federal government revenues. Malaysia have achieved universal healthcare coverage. It has made remarkable progress in improving health outcomes over the past 7 decades, including reducing infant mortality and maternal mortality. Malaysia has been acknowledged globally for high-performing health system based on well-trained workforce, excellent infrastructure, and quality service delivery. It has a low incidence of esoteric and information healthcare expenditure. According to the latest available data, less than 1% of the population spend more than 35% of their household budget for health. However, we are faced with many public health challenges. Not only do we have silent epidemic of non-communicable disease or NCD, but we also face with newly emerging or re-emerging communicable disease. The COVID-19 pandemic had demonstrated the close relationship between communicable disease and NCDs, resulting in what is known as syndemic. A syndemic happens when two epidemics occur at the same time, in which the interrelated biological factors work together to make the health outcome or disease worse. In addition, Malaysia is also fast becoming an aging population. Therefore, during the COVID-19 pandemic, we saw the people living with NCD and the older age group were at higher risk at severe COVID-19 infection and deaths. Providing healthcare services for this population had put a severe strain on our healthy care system. Ladies and gentlemen, as we are now transitioning towards endemicity for COVID-19, we need to take stock and learn from our experience, particularly during the peaks of COVID-19 pandemic. People living with NCD face disruption in the management of their disease, leading to delayed diagnosis, treatment, and care. However, we have taken many steps to mitigate and minimize their disruption, including decanting specific services to the private healthcare sectors, telehealth services, and delivery of medication to the patient's home. While I can safely say that the delivery of healthcare service is back to pre-pandemic days, we now have to contend with long COVID, with more and more evidence showing increased risk of NCD and possibly adding the demand for long-term healthcare services. The main cause of death of Malaysia are due to NCD, and nearly 70% of all premature deaths are linked to NCD. We also know that Malaysia has the highest prevalence of people living in the hypertension and diabetes in the Asian region. Therefore, it is a real challenge for us to achieve the United Nations Sustainable Development Goal number 3 or SDG 3, in particularly SDG 3.4, to reduce by 1/3 premature mortality from NCD through prevention and treatment, and promote mental health and well-being. Not only the Ministry of Health will continue to struggle to deliver quality care to people living with NCDs at the individual and household level, the rakyat will continue to suffer from ill health, affecting their ability to work and risking financial hardship. Ladies and gentlemen, over the past decades, the Ministry of Health has taken many initiatives to strengthen the delivery of quality care to all Malaysians. One such commitment is Enhanced Primary Healthcare Initiative or NPHC, which aims to improve quality of care for people living with diabetes, hypertension, and high cholesterol. Through the MPRIT services, the MOH has strengthened smoking cessation service through public-private partnership with objective to make smoking cessation services accessible throughout the public-private sectors. The services were further enhanced with a quick line counseling system and website to promote and facilitate registration of smokers. However, we see significant demand on our healthcare system due to increasing burden of NCD and communicable disease and aging population and rising healthcare costs. What we need now, a major change to Malaysia healthcare system to meet the current and future health challenge while still maintaining affordability and financial protection, particularly to the lower socio-economic income group and vulnerable and disadvantaged population. In this regard, I would like to thank the previous Minister of Health for leading the Healthcare Transformation Plan, also known as the Health White Paper. This Health White Paper was built up a decade of work by the team at the Ministry of Health, and I would like to give credit to all the individuals who have worked on transforming our healthcare system over the many years. As stated by the Prime Minister, this current unity government will continue to work on plans or existing policy that benefit the rakyat. Therefore, it is essential that we move the Health White Paper agenda forward, as this is a crucial in ensuring continued universal health coverage to all Malaysians and to move Malaysia closer toward achieving the targets set under SDG 3. Ladies and gentlemen, I am aware that the silent NCD epidemic is complex, insidious and huge. To fulfill universal health coverage for NCD is an ambitious target and thus requires a multi-sectorial, multidisciplinary and multi-stakeholder effort which extend beyond the health sector, just and how the sustainable development goals are all interlinked with one another. Other ministries and government agencies also have immense power and potential to help reduce the burden of NCDs. This is because the exposure of our population to NCD risk factors are largely determined by policies in trade, labor, finance, urban planning, and the education sector, to name few. In this regard, the Prime Minister had also instructed the Cabinet to move away from the silo approach toward a multi-ministerial approach in addressing the various challenges faced by the rakyat. Once both the Minister of Health and myself have been briefed on the Health White Paper, we shall strategize on how best to move forward together with the other related ministries. However, we also would need to support of the rakyat, and therefore civil society organization and NGO also play a crucial role in helping us achieve this health goal. Health is the basic need of the rakyat, and we will meet it. As the United Nations Sustainable Development vow, we will leave no one behind. I would like to officially open this event. Thank you.
Terima kasih pada pagi ini NCD telah memberikan satu kejutan yang sangat besar buat saya dan juga Fraternity of Health berkenaan tentang kita dapat menghimpunkan ketiga-tiga mantan Menteri Kesihatan di atas satu kertas dan juga telah memberikan satu pandangan yang hebat dan juga pandangan yang saya ambil kira akan saya sampaikan kepada Yang Berhormat Menteri, terutama sekali pandangan-pandangan the success stories dan juga kejayaan yang belum lagi kita dapat, terutama sekali dalam pelaksanaan dan juga dengan membentangkan the white paper of health. Dan juga sudah pasti saya telah meneliti apa yang telah disebutkan oleh saudara KJ Dr. Zul. Apa yang perlu dilakukan adalah dengan melakukan apa yang telah tersedia, dan saya akan memastikan Yang Berhormat Menteri akan meneliti dan kami dalam proses untuk mendapatkan ruang untuk memahami semua konteks-konteks yang telah diperolehi dalam white paper, dan seperti apa yang telah pengalaman yang disebut oleh Tan Sri Subramaniam ketika mengetuai kementerian, sudah pasti akan saya guna pakai untuk sepanjang tempoh penggal ini untuk memperbaiki, menambah baik dan juga untuk memberikan satu perkhidmatan kesihatan yang berkesan kepada rakyat. Dan sudah pasti pesanan yang amat berhormat Perdana Menteri yang menekankan bahawa PKM perlu bekerja keras dan juga tidak bekerja secara silo akan kita terima, dan saya dan yang berhormat Menteri kini sedang bekerja keras untuk memastikan apa yang telah diusahakan oleh semua mata-mata menteri, semua pasukan yang telah menyediakan white paper ini akan kita guna pakai untuk kebaikan rakyat. Dan juga pada hari ini adalah merupakan satu hari yang memberikan saya banyak maklumat dan input-input yang berguna untuk diguna pakai di dalam KKM kelak.
Selain daripada mengambil usaha dan white paper seperti ini, will you call or bring it back
Ya, semalam saudara KJ Mantan Menteri Kesihatan telah berjumpa dengan Yang Berhormat Menteri dan saudara KJ bersedia untuk memberikan pandangan dan maklumat, dan Tan Sri Subramaniam juga telah memberikan input, Dr. Zul telah memberikan input, dan di dalam sosial media, Twitter, ciapan internet telah kita sedia maklum bahawa kesemua mereka bersedia untuk membantu, dan saya sebagai Timbalan Menteri akan mengusahakan agar kesemua pandangan-pandangan ini diterima pakai, dan kita akan menyediakan satu platform khusus. The engagement must be ongoing dan kita kena lakukan dengan segera mungkin. Okey? Alright. Okey. Sudah pasti kalau saya dengar daripada NCD sini, cabaran besar seperti diabetes, kolesterol, high kolesterol, obes adalah masalah utama. Saya cukup yakin untuk menjawab dengan teliti, saya tidak mampu untuk menjawab dengan teliti, tetapi apa yang saya dapat katakan adalah kita memberikan perhatian kepada apa yang telah disebut, dan juga kita akan mengambil maklum dan juga akan melaksanakan apa perkara-perkara yang mengurangkan permasalahan ini pada umum. Okey.